clinical anatomy of the abdomen, a pain or some disorder or some disruption in the abdomen. Now, an abdomen is also known as the Pandora's magic box. Now, clinical anatomy, congenital, trauma, infection, inflammation, tumor, procedure, therapeutic and diagnostic. You just divide this in, it might be congenital, it might be due to some trauma, infection and inflammation, tumor and procedure, therapeutic or diagnostic. Next. Now content, introduction, applied anatomy and applied physiology, esophagus, stomach, small intestine, large intestine. Next. Now you see applied anatomy of the esophagus. Esophageal varices are dilated submucosal veins in the lower third of the esophagus. They are most often a consequence of portal hypertension. Commonly due to cirrhosis, patients with esophageal varices have a strong tendency to develop bleeding. Esophageal varices are diagnosed with endoscopy. Even the treatment is also with endoscopic maneuvers. Now, see, when a patient comes with an abdominal pain or something, then you ask him these questions that does he vomit blood? And the blood vomited from the stomach with the interaction of the action of the acid of the stomach, it turns into coffee ground color. Coffee ground color. Now and hemoptysis, any lesion in the lung, you see tuberculosis or some tumors or even bronchopneumonia. If the patient coughs, that might be blood stained, but severe hemoptysis in your there due to coughs, but a patient, the difference between gastric hemorrhage, the patient, the chances of dying is more. But a patient with hemoptysis, he doesn't die as being compared to gastric hemorrhages. So if you encounter a patient with a coffee ground vomitus, then take your utmost, your skill and diagnostic procedures, you hospitalize and then emergencies, collect blood and manage the case. Now, next. Now, applied physiology of the esophagus, dysphagia and esophageal achalasia. Next. Applied physiology is dysphagia. Dysphagia means difficulty in swallowing, causes mechanical obstruction of the esophagus due to tumor, stricture, diverticular hernia, outpouching of the wall. Now, the decreased movement of esophagus due to neurological disorders such as Parkinsonism, muscular disorders leading to difficulty in swallowing due to oral stage of esophageal stage. Next. Now, esophageal achalasia. Esophageal achalasia is a neuromuscular disease characterized by accumulation of food substance in the esophagus. It is due to the failure of lower esophageal or cardiac sphincter to relax during swallowing. The accumulated food substance causes dilatation of the esophagus. The features of the disease are dysphagia, chest pain, weight loss, and cough. Okay, next. Now, displacement of the stomach, pancreatic and pseudo cysts and abscesses in the omentum, bursa and may push the stomach forward anteriorly. This displacement is usually visible in lateral radiographic or CT. You do a radiographic examination first because CT will take some time, and then try to diagnose, evaluate, and accordingly you send for CT thorax. It is the abdomen. Now, the posterior wall of the stomach may adhere to the part of the posterior wall of the omentum bursa that covers the pancreas. This occurs due to inflammation of the pancreas, and it is very close to the posterior wall of the stomach, the pancreas. Next. Now, cancer of the stomach, stomach cancer, also known as gastric cancer, is cancer developed from the lining of the stomach because the lymphatic vessels of the mucous membrane and submucous of the stomach are continuity. It is possible for cancer cells to travel to different parts of the stomach. Now, next. Gastric pain, the sensation of pain in the stomach is caused by the stretching or spasmodic contraction of the smooth muscles in its walls and is referred to epigastrium. It is believed that pain transmitting fibers leave the stomach in company with the sympathetic nerve. They pass through the celiac ganglion and reach the spinal cord by the greater splanchnic nerves. Next. Gastritis, inflammation of the gastric mucosa is called gastritis. You have some alcohol and also heavy food, and that is some spicy food, regular basis, at least thrice a week, then you will be getting gastritis. And now it may be acute or chronic. Acute gastritis is characterized by inflammation of the superficial layers of the mucous membrane and infiltration with leukocytes, mostly neutrophils. Chronic gastritis involves the inflammation of even the deeper layers and infiltration with more lymphocytes. It results in the atrophy of gastric mucosa with loss of chief cells and parietal cells of the gland. Therefore, the secretion of the gastric juice decreases. Next. Now, peptic ulcer means erosion of the surface of any organ due to shedding or sloughing of inflamed necrotic tissue that lines the organs. Peptic ulcer means an ulcer in the wall of the stomach caused by action of gastric juice. Its peptic ulcer is found in stomach. It's called gastric ulcer. Next. Gastric atrophy. Gastric atrophy is the condition in which the muscles of the stomach shrink. The muscles of the stomach shrink and becomes weak. The gastric glands also shrink, resulting in the deficiency of gastric juice caused by loss of gastric gland. Next. Now, a duodenal ulcer is a type of peptic ulcer that occurs in the duodenum, the beginning of the small intestine. Here. As the stomach empties its contents into the duodenum, the acid chyme is squirted against the anterolateral wall of the first part of the duodenum. Next. Gastric ulcer commonly seen on lesser curvature, and gastric carcinoma commonly occurs at the pyloric antrum and greater curvature. You see the site. And Zollinger-Ellison syndrome, treatment is vagotomy, gastrin-bearing stomach mucosa, antral gastrectomy. Next. Now, ulcer and gastrectomy. Now, you see the peptic ulcers here. Now, part of all of the stomach is removed. This part is removed, and intestine to join to the stomach. The intestine is joined with the stomach. It's a bypass operation. And your Professor Sumit Sannal, the head of the Shantiniketan Medical College Surgery, he is a master in gastrointestinal surgery. And I hope that by the time you reach studying surgery or finishing college, then you might get the chance of seeing these types of surgery. Now, peptic ulcer, the stomach. Peptic ulcers may lead to bleeding, perforation, or other emergencies. This is very important. See, if a patient, now, previously, in our days, there were It was an acute emergency. A number of peptic ulcer incidents before the PPI came into the market. Now, if you see any uh, Anushthan Bhavan, a marriage hall or something, or some party is going on, a bus is there, if there is a chemist shop, people run to the chemist shop and take some PPI before going into the party. But these incidents also decreased, though other symptoms or other problems may develop, but even any heavy food is being made in your home, you take a PPI. And that is due to, and that the incidence is decreased now. But whenever you are the history in the emergency, the patient will say, you have anything, do you take some drug, or your analgesics. That may aggravate the previous peptic ulcer. As a result, there might be perforation. It is the emergency in perforation operation. If they do a laparatomy incision, open and repair the ulcers that is perforated. And by sometimes you will be seeing if the patient is coming late to you, the omentum will be trying to control. The omentum is also known as the policeman of the abdomen. Now, and before the closure, they put a omental patch on your the area where the perforation has occurred. Okay. Now, duodenal ulcers, an ulcer of the posterior wall of the first part of the duodenum may penetrate the wall and erode the relatively large gastroduodenal artery, causing severe hemorrhage. So you have to keep this in mind. If you see when you open the abdomen, then you might see the pool of blood, or the peritoneal fluid is stained with blood. Then you have to see that the posterior wall might be perforated. As a result, then you have to peritoneal wash, and you have to suck out the blood clots and other ingredients, and then a clear view, the stomach now, if this is the, even if there is, you stomach then you can see you won't be cutting on the stomach directly now. And you see, and there you will try to repair, the surgeon will try to repair, and now as the stomach empties its content into the duodenum, the acid chyme is squirted against the anterior wall of the first part of the duodenum. Next. Now you see peptic ulcer, Zollinger's-Ellison tumor in pancreas, and this is the duodenal ulcer due to hyperacidity. Next. Now malabsorption. Now malabsorption is the failure to absorb nutrients such as protein, carbohydrates, fat, and vitamins. Malabsorption affects growth and development of the body. Now, if a patient is looking cachectic and the skeleton is visible with just skin and muscles, and a presentation is like this, then you ask the patient's mother Does he take food properly or not? Okay. Next. Now you see Crohn's disease. Crohn's disease, enteritis. Crohn's disease is enteritis. Enteritis is an inflammatory bowel disease characterized by inflammation of the small intestine. Usually it affects the lower part of the small intestine and the ileum. The inflammation causes malabsorption and diarrhea. Now a person comes with your certificate. Sir, you please issue me a certificate. I've bunked my class, or I'm not gone to office. Then there are two things. Immediately, in an emergency, means the patient wants you are in your chamber. It's up to you to issue a certificate or not. But you can give two problems. He is suffering from acute gastroenteritis, and he's advised here for complete rest. এটা মিথ্যা হতে পারে, কিন্তু you will be in problem. If your friend or your husband or your wife is a working woman, then if she comes দার্জিলিং ঘুরে চলে এলে, তখন তুমি বলবে আমার একটা সার্টিফিকেট লিখে দাও. You write a certificate that you give gastroenteritis or backache. It's very difficult to until you do an MRI or CT or something. So just a joke I've cracked, that these are the two diagnostic things which you can put it in your the thing, medical certificate. কেউ ধরতে পারবে না তোমায়, কারণ তোমার লাইসেন্সে যেন থাকে. Okay, now that's a joke. You should judgment is yours to issue a certificate or not. That is, you must be very judgmental. Now, steatorrhea is the presence of excess fat in feces. Stools may also float due to excess gas, have an oily appearance, can be especially foul-smelling. Steatorrhea is the condition caused by deficiency of the pancreatic lipase and resulting in malabsorption of fat. Now, see, in routine examination of stool is a must, and you put occult blood. It might be due to worms, it might be due to this thing, and if the pathologist gives you a report of steatorrhea and presence of excess fat in the feces. So, see, small diagnostic this thing advice you have to put in, that is routine examination of stool. If any person comes with a history of black tarry stool, then you ask the patient, যে আপনার কি কালো আলকাদ্রার মতো পায়খানা হয়েছে, or was the stool black as your hair? Then you think that there is bleeding from the upper GIT. So, because in piles, it will be frank red colored blood. So, you give a routine stool examination, and also when you give a treatment, then you give anti-hemorrhagic drugs, your other enzymes, and other your occult blood is there, then you give a anti-hemorrhagic drug, and also you see the stool report, then you go for an enzyme, that is lipase amylase test. Lipase amylase test for now celiac disease. Celiac disease is an autoimmune disorder characterized by the damage of mucosa and atrophy of villi in small intestine, result digestion and absorption. It is also known as gluten-sensitive enteropathy. Gluten-sensitive enteropathy. See, in normal, the histology is such, and this celiac disease is this. You see the projections of the mucosa, and you see it is in clustered form. Now, what I want to say is that the endoscope is now more or less at Bolpur. Every day of the week, so 4 days in a week, you will find some gastroenterologist is doing endoscopy. So if you are suspicious, then you just write that biopsy of any disorder and also root test, that is for H. pylori, because most of the previous days it was of the hyperacidity was thought, and vagotomy used to be done usually for this thing, gastritis and gastric ulcers. But the thing has changed that H. pylori is the culprit, which is a bacteria that produces hyperacidity and also the ulcers. So you give a course of drugs that kills the bacteria. But again it resurges or comes back. So what I do personally, because honey has a role in killing H. pylori bacteria. And so how many days will you give up the antibiotic? And how many doses? Maximum 20 days or 1 month. But the rest period, what I do is that I prescribe 2 teaspoons of honey in the morning in empty stomach, half an hour before lunch, half an hour before dinner. And then when every patient cannot be sent for an endoscopy, you have to do a clinical judgment. You have to relate your complaint with the presentation of the patient. This is one thing. But you have to keep in mind that if you're a busy practitioner, so you keep 2 things in mind. Your gadgets, your diagnostic tools are available. It is available. Previously, for gastroduodenoscopy, you used to send to Bardhaman. Even I had to do it with Dr. Gautam Das of Amri. I used to send a patient from my clinic to Kolkata. Now, these things have changed. The scenario will change more when you are an established doctor or just pass out doctor. Now, you see, now pain of appendicitis. Now, the visceral pain in the appendix is produced by distension of the lumen or spasm of the muscles. The afferent pain fibers enters the spinal cord at the high level of the 10th thoracic segment, and vague referred pain is felt in the region of the umbilicus. Later, the pain shifts to where the inflamed appendix irritates the parietal peritoneum. Now, any pain on the right side, right iliac fossa, does not relate to appendicitis. Even if it relates to appendicitis, then you be sure that would you go for an immediate surgery or not. Now, what happens usually, surgeons, now the work of the general surgeon is decreased. Now, any pain on the right iliac fossa, appendicitis. And but if another patient comes, you say you have a heart attack, you go to the clinic. Na babu, amar gas ache, amar peter rog ache, amar hearter kichu nahi. But people they are so serious about appendix that they try to persuade you that now I'm doing surgery kind of thing. Now what happens in a day, if you are reluctant to refuse that, no, it's not appendicitis, it is appendicitis, but it does not need surgery immediately. If a small kid or small child, if there is a pain, it might be due to, first thought should be your worms. So you deworm, give antibiotics and wait for in 6 weeks, but they have to report to you 10 days interval. So that is, or if there is a lump in the appendix has burst, it has perforated, not burst, I'm saying. This has formed a momentum and all this. There's abscess over here. The USG report will give you this picture. Just leave it alone and you manage the medical management of the surgical patient. This is the word you must keep in mind, that medical management of the surgical patient. You manage with medicines and proper IV fluids, infusion, antibiotics, and then after 6 weeks, you can go for, because if you, at this stage, you want to operate, then you have to put in drains and this thing, that will be messing up. It might be the ileum is adherent to the lump. You have to, but if you open, then you will have a feeling that, now I have to do something. But that is a catastrophe. Because nowadays antibiotics are there, so you can manage a perforated appendix with lump, followed by serial ultrasonography, and then go for surgery. Now, diverticulosis is also known as diverticular disease. It is the condition of having diverticula in the colon, which are outpocketings of the colonic mucosa and submucosa through weakness of the muscle layer, and in the colon wall. This is the picture. This is the picture. This is the picture. Now, these are more common in sigmoid colon, which is a common place for increased pressure. This is uncommon before the age of 40 and increases in incidence after age. So, a young person comes below 40, don't think of diverticulosis. You might keep it in mind. Next. Now, diarrhea. Diarrhea is the frequent and profuse discharge of intestinal content in loose and fluid form. It occurs due to increased movement of the intestine, cause dietary, excuse me, dietary abuse, infection, intestinal diseases. Now, dietary abuse. The diet you are taking, chicken pakora, chili chicken, drumstick. In one dinner, this thing you are taking so much protein and also Ajinomoto, sauce, this sauce, that sauce. Okay, that also irritates your system. Next. Now, constipation. Failure of voiding feces which produces discomfort is known as constipation. It is due to lack of movement necessary for defecation. Due to the absence of mass movement in colon, feces remain in the large intestine for a long time, resulting in absorption of fluid, so the feces becomes hard and dry. Now, in diabetics, constipation is a problem. So you have to, this lifestyle management, even in piles, hemorrhoids, you lifestyle management, you lots of vegetables and your fruits, lots of fruits, water, that will give the relief. Now, abdominal and surgical incision. Now, incision should be made, if possible, at lines of cleavage. Collagen fibers in dermis are parallel. More narrow scar, skin incision away from the nerves. Muscle atrophy if nerve cut, shorter healing time. Now, this is that's why you'll see some incisions are there. And in appendicectomy, there are 4 incisions that is visible in the abdominal wall. But I have developed an incision which awarded me a gold medal. That is, Now, this is the McBurney incision. McBurney. What I do is that in the iliac crest ligament line, I stretch the skin like this toward the umbilicus, and I make an incision, and then go through McBurney's point and the gridiron muscle splitting, and take out the appendix, do the appendectomy, and the skin comes up in this line. So if you wear a Bermuda or a bikini or a swimsuit, the scar is not visible, or a sari below the navel, it is not visible. I will show you that, not today, I will show you on the next day. The paper was on 11 minutes. In those days, in 90s, I had drawn, there was no PowerPoint that time. I had drawn, my handwriting is not good. Anyway, that things I took the photograph in the and slides I prepared, and I put a video clip of 2 minutes, and that was, and this thing, because of now laparoscopy in those days was not available. If at all it was available, it was in some private hospitals in Kolkata, Bangalore, or something like that. So I had written that where laparoscope is not available, where your but so the incision was there, and but today, if you go to the site, medical dialogues, now you will find that a paper in United States or some foreign countries that they have come, now they are evaluating laparoscopy with open cecal appendicectomy. Now laparoscopes, now they are saying no, open, this thing is more better. Because when you read the anatomy of appendix, then you will see how much critical it is. So at times, and there are two places, that is the ileum going into the ileocecal valve and going to the cecum. Now, in these two areas, most catastrophes happen. That's why if with a lump, you don't go for immediate surgery, because antibiotics, higher range of antibiotics are there, and also you won't mess up. No. Next. Now, category of incision, midline, transverse. Next. Maillard incision, PFN-Settle incision, Chardin's incision, Custer's incision. Next. Now you see linear semilunaris, inguinal ligament, arcuate ligament, McBurney's incision. My incision is in this place, this level. So it happened so that a boy I had operated, after 5 years he was suffering from acute abdomen pain, acute pain of the right iliac fossa, and he went to one surgeon, I won't be naming him, and went to this thing, Bolpur nursing home. But the doctor said, no, appendix operation korte hobe, appendicitis. So what happened? He actually did not see. Only he put his hand like this and said, but he just did not remove the clothes or something like that. The incision was not visible in the abdomen. I don't blame him. But when I see if that any patient after 10 years or something like that, then the patient comes, for some other complaint, I try to see and look at it. Toh operation jagata kothay nahi dekha to na dekha jaye na. And that is one thing. Now incision line is very important. Linea alba and McBurney. Now why in some cases, now in appendicectomy, actually if it is not available, it is not in the right iliac fossa, It might be you are reading embryology and you will see that this is the liver, this is the gallbladder. Now, the cecum is here. Now, cecum is here. The appendix is here. Now, this is the right iliac fossa. Now, Magbardi's incision is there. Now, the surgeon is desperate. He doesn't find an appendix on the right iliac fossa. It might be in the left iliac fossa. In those days, there was no investigations. So, he cuts and goes up. So, this type of incisions are made extending that incision. But in case, if there is a like this subhepatic cecum and appendix, then you can simply close the incision and make a midline incision and then deliver the appendix and cut. Okay, this is the advantage. Next. Now, palpation of the abdomen, soft and pliable, inward and outward excursion of the respiration from right inguinal region to left hypochondrial region. Contour of abdominal wall depends on the tone and fat, finding lumps in large organs such as liver, spleen, dilated veins, skin, discoloration. This is the clinical part. When you go to clinic, you will see that you have to palpate, and from down to upward you see if you can palpate the liver is a large 2 fingers or 3 fingers, or you go from right iliac fossa and then go up to the spleen, the splenic area, and see if the spleen is enlarged or not. And of course, if there is a lump in the lady, then it might be from happening in the uterus or the ovary. Now, accordingly, you take USG and find what is the exact problem. Next. Now, you see dilated veins in the anterior abdominal wall. The dilated veins in the anterior abdominal wall. Now, these are the clinical manifestations you will be seeing in your day-to-day practice, and you will find that the things are there. I can clinically diagnose the pathological condition of that person. Next. Palpation of the superficial inguinal ring looking for indirect hernia. Male palpate somatic cord in upper part of the scrotum. Form cord-like structure. Posterior is a vast difference. Patient coughs it to increase intra-abdominal pressure. Female, smaller and difficult to palpate. Transits round ligament. Now, inguinal hernias are not uncommon in females. So, a girl of 5 years, 6 years, or even 3 years, the mother comes with a complaint that there's a swelling here. Then you palpate and see and make her to cough and see in the inguinal, if there's a swelling, you confirm with your USG and say that it's a hernia. Next. Now, umbilicus. Now, meeting point of CBS, gastric during development, hotbed of embryology. Skin around umbilicus supplied by T10 spinal segment. Surgical incision should never be crossed umbilicus. Congenital defects include omphalocele, hernia, and fistulas. So, next. Now you see the omphalocele. Now, immediately in the labor room, if a baby is born like this, it used to be born like this. This is the omphalocele or some twins, thoracophagous, craniophagous, all these twins. But now, due to your NT scan and your anomaly scan between 19 to 22 days, 2 weeks, you have to do an anomaly scan. And with this advent of your modern diagnostic tools, USG is one of the best tools, I told you, and cheap. Naturally, if you diagnose like this in the anomaly scan of any lady or some cleft lip or some anomaly in limbs. So you have to avoid this thing, because these operations are very difficult and only few in India used to do, and some good pediatric surgeons. Now, hernia classified as external, internal. Inguinal hernia can be classified direct, indirect. Indirect further classified as complete, incomplete. Now see, the external hernias are epigastric hernia, umbilical hernia, inguinal hernia, femoral hernia. Now this epigastric hernia, a patient comes and says that I am having some acidity or gastritis or peptic ulcers. He doesn't say that. But আমার কিরকম যেন গ্যাস হচ্ছে, একটু কিরকম যেন অম্বল হচ্ছে, complain. You try to, এই এখানে কোনো ফুলে যায়, এর রুটিন জিজ্ঞেস করবে। When you are palpating and see if there is a swelling coming out, এটা কি ভেতরে ঢুকে যায়? বলে শুয়ে পড়লে ভেতরে ঢুকে যায়। Then think of that it is a epigastric hernia. Umbilical hernia, of course, is visible. You can see inguinal hernia, femoral hernia is also visible. Now, see the layers of the hernial sac. Now, you see the total layers. This is the hip bone, and these are the layers. This is the intestine. Next. Now, you see the epigastric or ventral hernia. See, it's such a big hernia. Hernial sac. Scar, repaired hernia. Now, linea alba, you can see rectus abdominis and hernial sac here. The anterior rectus sheath, posterior rectus sheath, and peritoneum. This is the peritoneum. This is the. Now, you see umbilical or paraumbilical hernia, congenital umbilical hernia. This is the congenital umbilical hernia. Incomplete closure of umbilical ring. Now, acquired umbilical hernia occurs closure of umbilical ring to 2° to obesity, pregnancy, cirrhosis, ascites, and masses. Now, this is the umbilical hernia acquired, and this is omphalocele. See, this is the amniotic covering of the sac. This is the umbilical cord. This is the intestine inside, and you see the umbilical vein and the intestine here, the abdominal wall. This is the picture. This is a diagrammatic or schematic drawing of this omphalocele baby. Now you see the Spigelian lateral ventral hernia. This is the appendix of the external oblique. This is the internal oblique. This is the rectus abdominis, transversus fascia, and peritoneum, and the intestine. Now, frequent hernial site is this rectus abdominis, this site. Arcuate line is here. Frequent hernial site. Now, semilunar, rectus sheath and posterior anterior lamina, and this is the transversus fascia. This is transversus fascia. Now, femoral hernia, you see the femoral vessels. Now, this is the femoral ring. Now, the herniation occurs here through the femoral ring. Femoral hernia orifice, sac, and fascia lata. It is in this place. So, whenever you are examining the patient complains of swelling here, then you think of inguinal hernia, direct, indirect, and also the femoral. Now, in this, when you take off the clothes, you palpate the pulsating femoral artery. Now, femoral and medial. Now, medial to it is the femoral vessel, the femoral vein. Then you go more medially. This is the pubic symphysis pubis, and then you see the opening. This is the femoral hernia. Yeah, femoral canal. Now, hydrocele. A picture of hydrocele. Next. Now, Hydrocele is congenital, persistent processes vaginalis congenital. Fluid-filled sac tunica vaginalis surrounds the testicles. 1 in 10 male infants at birth, typically not painful or harmful. Other causes infection, trauma, tumor. Differential diagnosis is hematocele, pyocele. This you will encounter in your any hydrocele you see. These are the pictures. Next. Now you see the varicocele. This is the penis and this is the scrotum. You see the bag of worms. It's like a bag of worms. If you put worms, earthworms in a plastic packet, a bag, then you feel the feel you feel, and you'll see similarly, mostly varicocele in the left varicocele. You can palpate and see, and the patient will bring you or not. He'll bring you to the problem he is having. Next. Now, see, pampiniform plexus testicles becomes dilated, tortuous, thickened, lengthening. On inspection, bag filled with worms. Common in adolescents, mostly left side due to connection with the renal vein versus right side, which is joined with the inferior vena cava. Now, this is the thing that the left side due to renal vein. Now, could be caused by primary kidney disease, patient presents with infertility, plexus not cooling. Okay, next. Now, testicular cancer spreads upward via lumbar limb to L1, later spreads locally to superficial inguinal leads. So, if there is a cancer of the testes, then it spreads to the lumbar 1 level. Next. Next. Now, torsion of the testicle, rotation around somatic cord, often associated with excessively large tunica vaginalis. Active young men and children, severe pain could lead to testicular necrosis. Now, torsion of the testes, you see the picture at operation, and this is the torsion. Now, this can be acquired during surgery of the hydrocele. After eversion of the sac, if you see the sinus of the epididymis is only your right side laterally, only medially. But if you do if you by when you personally put it with a twist, you put inside the scrotal sac, that can be a torsion, acquired torsion. Next. Now, peritonitis, inflamed parietal peritoneum is extremely sensitive to stretching. Pressure applied to abdominal wall with one finger. Rebound tenderness. Now, rebound, what is rebound tenderness? So, when you press, if there is a for acute pain in appendix or any peptic perforation, then it will rebound. Or having cholecystitis, Murphy's sign. Then you lying down, you take a deep breath, ask the patient to take a deep breath and put your finger. Then you say, ouch. So that can be, that's Murphy's sign. So clinically, we used to diagnose that it is cholecystitis. Okay, next. Now, ascites. Now, see the huge ascites. Next. Now, ascites and paracentesis, excessive accumulation of infiltratory peritoneal fluid, 1.5 liters before clinically recognizable. Local anesthesia, needle through abdominal wall, either through linea alba or lateral to McBurney's point. Skin, superficial fascia, deep fascia, aponeurosis of muscle of the external oblique, internal oblique muscle, transversus abdominis muscle, the fascia transversus extraperitoneal connective tissue and parietal peritoneum. The total, the abdominal wall muscles, you put a needle. Next. Peritoneal adhesions associated with peritonitis, post-surgical gynecology in general as well. Adhesions occurred in more than 90% of the patients following major abdominal surgery, and in 50 to 55 to 100% of the women undergoing pelvic surgery. Small bowel obstruction, infertility, chronic abdominal pain, pelvic pain, and difficult reoperative surgery are the most common consequences. Now, what if you become a become a surgeon or a gynecologist? You're doing any surgical maneuver, then you have to be very gentle. The one thing is that handling of tissues very rough, or you're clamping or cutting, that leads to post-operative adhesions. Next. Now you see the peritoneal dialysis. This is the solution bag. This is the catheter. This is the catheter inserted and placed in the recto-uterine pouch, and drainage bag. This is the drainage bag, the peritoneal dialysis solution. Now peritoneal. Now volvulus, see the condition of the intestine. This is volvulus. Next. Now appendicitis, afferent pain fibers enter the spinal cord at the level of T10 segment, and vague referred pain is in the region of the umbilicus. Later the pain shifts to where the inflamed appendix irritates the parietal peritoneum. Here the pain is precise, severe and localized. Next. Appendicitis. Now you see, this is a picture from NETA, acute appendicitis and gangrenous appendicitis. Now this is the appendix in surgery. Next. Appendicitis, inflammation of appendix is known as appendicitis. The appendix does not have any function in human being, but it can create major problems when diseased. Appendicitis can develop at any age. It is very common between 10 to 30 years of age. Next. Now, cirrhosis of liver. Hepatocytes undergoes necrosis caused by the inflammation. Dead hepatocytes are then placed by fibrous tissue, cirrhosis liver, IV intravenous compression, and portal hypertension. These are the cause of portal hypertension. Now, portal hypertension, you see the liver, the portal vein, veins from pancreas and duodenum, veins from ascending colon, and veins from jejunum and ileum, the inferior mesenteric vein, superior mesenteric vein. And you see the left gastric vein, splenic vein, and short gastric vein in the esophageal veins. Next. Now, colitis, pain, tenderness in the abdomen, fever, swelling of the colon tissues, bleeding, erythema, redness of the surface of the colon, rectal bleeding, and ulceration of the colon associated with Crohn's disease, ulcerative colitis. Next. Colostomy, cancer of the large bowel, minimal invasive laparoscopic surgery, lymph vessels and lymph nodes removed. Next. Ileostomy, small intestine brought out to the skin, collected in a pouch, usually done in groin region, ulcerative colitis, Hirschsprung disease. Next. Colonoscopy, colorectal cancer is leading cause of death in Western world. Bowels washed, patient sedated, and tube inserted. Next. Rupture of the spleen associated with trauma, mononucleosis, requires immediate medical and surgical attention. Severe blood loss in splenomegaly, left side T9 to T11 removed rather than repaired, total splenectomy. You do a total splenectomy, and if you see in USG, you will see that splenomegaly, hepatomegaly, so how much it is increased in size. You have to see it and then accordingly decide whether medical management or surgical management. And patient becomes, in previous days, malaria was a cause of enlarged spleen. So, next. Now, pancreatic cancer. Now, near head of the bile duct, obstructive jaundice, the yellow skin tint, Whipple procedure, pancreatoduodenotomy, stents would all do well. Now, nowadays, by the gastroenterologist, he puts a stent. If there is any obstructive features in the hepatobiliary system, then they put a stent through the endoscope to relieve the jaundice and later proceed for major surgery, surgical uh, uh, maneuvers. Now, next, impaction of gallstones, usually asymptomatic, sometimes very painful. Eating fatty foods, contract gallbladder against stones, may result in infected bile into the pancreatic duct, leading to pancreatitis. So, surgical removal by cholecystectomy. But if you have to see that the infection is controlled and also the jaundice is reduced. So if the stones is impacted in the or some in the ampulla of Barter or in the bile duct CVD, then you go for your endoscopic removal of the stones. Next, cirrhosis of liver, scarring of liver tissue as hepatocytes die off, associated with chronic alcoholism and hepatitis. Portal hypertension develops. Portal hypertension develops.